Hello, everyone. Thank you so much for joining us tonight. My name is Taylor Mead, and I am the Director of Health Programs for Special Olympics New York. So we really want to thank you for taking some time to join us for this presentation. And hopefully you will find this very informative and have a lot to be able to take back, whether it's into your practice, into your career, or back to your family or yourself, depending on whoever you are. Just a little background on our health forums. So these are resources for the intellectual disability population, their caregivers, their supporters, providers, anyone who is looking to support the IDD population. And one of our great supporters is our presenter tonight, Dr. Ben Margolis. So Dr. Margolis is board certified in neurology and psychiatry, having completed the combined residency program at Brown University. He specializes in neuropsychiatric care for adults with IDD in the New York Hudson Valley. He attended medical school at the Albert Einstein College of Medicine after the post-baccalaureate pre-medical program at Columbia University and holds a BFA from the School of Visual Arts in New York City. An active member of the ADMD and currently the treasurer. He is working to improve behavioral and mental health care of individuals with IDD on local, state, and national levels. So I'm going to hand it off to Dr. Margolis, and please hold any questions that you have until the end. If we have some time, we'll have the opportunity to ask those questions, and if not, we will also provide a form link where you can submit any feedback and questions. Dr. Margolis, it's on to you.
Hi, I'm so honored to be able to share with you guys. Thank you to all who are on the call. I serve as a member of the Special Olympics New York Health Advisory Council for the Strong Minds program, and I'm so honored to be included among that esteemed group and to be able to connect with Special Olympics New York, which is certainly a source of great physical and mental health care simply by doing what Special Olympics does. I am a neurologist and psychiatrist, so I specialize in neurobehavioral and mental health, behavioral health care for individuals with IDD. I hope IDD is an okay term to use for this talk. I'm going to refer to developmental changes and intellectual and developmental disabilities sort of lumped together and include autism within that. So I'm going to be speaking and addressing, let me just see if, are my slides showing okay?
Yes, yep.
Okay, great. So I have no disclosures. I'm currently working out of the Hudson Valley in New York for an agency called Access Supports for Living, out of their Article 31 clinic, where we have kind of crafted a specialty IDD program, and I provide about 90 to 95% IDD care now. And then the rest is general psychiatry, and I'm doing some behavioral neurology and dementia work. Let's see. So I just talked about who I am, what I do. I'm going to be talking to three distinct groups tonight. I don't know if we have clinicians. I'm going to be talking at the very end to clinicians, but otherwise I'm going to be talking to individuals with IDD and Special Olympics athletes. I'm going to be talking to families and caregivers, and I'm going to be talking about, first of all, basics of mental health and behavioral health care in IDD, why it matters, and why potentially it's so hard to access resources. I'm going to talk about when it matters, some of the most common presentations when people need behavioral health care. And then I'm going to talk about how to prepare, how to find access to mental health care in New York State, how to prepare, and some of the things that we can all do, even if an individual has no mental health challenges at this time. One of the things to make sure that you have that you have those resources available if you need them, such as, you see in the slide, ensuring OPWDD eligibility. So of course, I mean, I'm preaching to the choir. Oftentimes when I give a version of this talk, people aren't familiar with what OPWDD is, but I'm going to use a few acronyms. So OPWDD, of course, in New York State, is the Office for People with Developmental Disabilities. And I'm also going to refer to OMH, which is the Office of Mental Health. I may give some other acronyms later on, and I'll tell you what those mean at that time. But OPWDD is, of course, the primary funder. It's a Medicaid waiver program that's the primary funder of healthcare and residential services and programming services in New York State. And I'm going to be talking almost exclusively about New York State. Everyone in the audience is from New York State, I hope. If not, please let me know at the end, and I'll give my contact information if I can be of service outside as well. So we'll be talking about accessing healthcare. We'll be talking about some crisis resources, how to find a provider. I'm going to talk about basics of psychiatric healthcare, what we need to know, and how I can best do my job, so that you as an individual needing mental health care, or as a family member or care provider, that we can hit the ground running together. And then I'm going to give just a few bullet points and takeaways. At the very end, like I said, I'm going to talk to some clinicians, but if there aren't any clinicians, any adjacent care providers may find some of those resources helpful. So what I do, when I'm working not as a neurologist, but as a psychiatrist, neuropsychiatrist, or behavioral neurologist, primarily now my role is in psychiatric care because that's where the greatest need has been. I am treating mental and psychiatric illnesses, mental illnesses. So what does that mean? Those are disorders of mood, anxiety disorders, bipolar disorder, where for periods you may have too much energy and not be able to control your behavior, or periods of depression, sadness, overwhelming shutdown, the wish to end your life or harm yourself. Of course, we intervene. I treat problems of thought disorders. Sometimes people can disconnect from reality, think things are real that aren't real, such as experiencing things like auditory hallucinations, hearing things that no one else can hear. So I treat thought disorders, schizophrenia, schizoaffective disorder, delusional disorders, things called personality disorders, where the way someone operates with other people and with the world at large can be very problematic for them. We can help them learn new ways to interact with the world and interact with other people so that they can live the lives they want to live. Of course, addiction disorders, trauma, which go together. I treat something called PTSD, post-traumatic stress disorder. And then in the setting of intellectual and developmental disabilities, there's the added layer of complexity where I treat problematic behaviors. And oftentimes that's the most common reason someone comes to my office, is an individual is struggling with the behavior that they can't control, or that is communicating something that I'm there to help interpret. So those behaviors often just are getting in the way of somebody's life or creating safety problems for them or others. So then in the setting of intellectual and developmental disabilities or developmental changes, I'm treating complex disorders. A lot of the time I'm treating neurodegenerative disease. I'm treating MS or autoimmune disease. This is outside of the setting of IDD. I'm treating intersectional problems where someone can have mental health challenges in addition to things like cerebral palsy and epilepsy, and it's difficult to figure out exactly what's going on. In the setting of traumatic brain injury, there can be multiple problems. So we're managing complex problems, and that's why I work as part of a team, and we're going to talk a lot about that later. So what are the most common reasons people come to me? What's the most common things I see in my clinic? It's very frequently it's in the setting of crises and difficulties with transition. And those things are often driven by someone who has autism and OCD, And there is a transition between adolescence and adulthood. Very frequently, that time in life is when some of these problems first emerge in terms of safety, or in the setting of transitions. Later on in life, someone moves from pediatric to adult care. Someone moves from the home they know to a congregate setting. Someone moves or someone's having changes because their programming is no longer available, or they've kind of aged out, or their physical needs have precluded the life they know. So a lot of the time it's in transition. I'm treating anxiety spectrum disorders like generalized anxiety disorder, panic disorder, which can present a lot of behavioral challenges for people, and can present very commonly with rage attacks and aggressions towards oneself or others. I'm treating, unfortunately, a lot of people with, I like to say, people with IDD, unfortunately, are faced with, and forgive the expression, but steaming piles of trauma. So I'm managing a lot of post-traumatic stress disorder and adjustment reactions, stress reactions, because it's not necessarily easy to navigate the world without accommodations when you're a person living with developmental changes, of course, as everybody on this call will be aware. And then what do I do? How do I do that? Is I look at behavioral challenges when they're presented as a puzzle. We solve that puzzle together, and I serve in an integrative role. I take all of the information available medically. I take the information available from behavioral healthcare teams. I take the information available from an individual themselves, and from families and caregivers. We put it together and we figure out whether a challenge it represents a psychiatric illness or mental illness that would be really well supported with medication, in which case I of course offer medication along with the team, or may not be. Maybe there's a medical issue, and so at that point I work to coordinate care and be part of the team to make sure that the problem at hand gets addressed. So why does this matter, and why is this such a challenge among the individuals we serve? Individuals with IDD are, of course, and everybody I'm sure on this call knows this experientially, are more likely to face a mental health challenge throughout their lives than those without IDD. Roughly 20% of people in the US, and most commonly, the most common mental health challenges are going to be the anxiety, depression spectrum disorders, mood disorders. Roughly 20%, but between 30, depending on where you look, and depending on the source, there's at least a 30, but potentially as high as a 60% prevalence of mental illness and behavioral health challenges among within someone's lifetime. And this is national data, and there's also data from several individual states, which is why the figures vary so much. So when does this matter? All of us on this call, I'm sure, are familiar with the kinds of situations we see. We see a lack of ability of emergency rooms, a lack of ability of the overall mental health and the standard mental health infrastructure to be able to manage these challenges. So we see it most acutely, and I spend probably the most amount of my time doing crisis stabilization. So we see someone who previously didn't have a behavioral health challenge, or who had a very well-controlled behavioral health challenge, suddenly have a behavior change. We see them present with aggressions and safety concerns, oftentimes around transitions, like I said before, repeated emergency room visits, repeated admissions medically or psychiatrically. When they are admitted psychiatrically or medically, we see longer stays because of behavioral health challenges that are occurring during the admission. And then we see lots of risks. The longer you're in the emergency room, the longer you're in a hospital, there are risks associated with that. They are essential, but not necessarily benign environments, and we want to spend as little time as possible in those environments. And then, of course, I've faced some of the worst and most difficult cases I've helped manage have been related to risks around law enforcement involvement, which is sort of and especially among people who are a minority population, in addition to having a developmental change. There's a lot of risk involved with behavioral health challenges and law enforcement involvements. So some fundamental takeaways. So I wanted to offer to families, to individuals themselves, this may be totally familiar and absolutely obvious, but not necessarily to everyone, especially when someone has really never had behavioral health challenges before, and when these things often emerge among certain challenges, it can be absolutely new and absolutely foreign. So the understandable assumption on the part of care providers and caregivers is that a new behavior represents an emerging mental illness, and it doesn't always. So we have to look at a behavior as a symptom, and we have to look at a behavior as a means of communication. The job of me as a healthcare provider and of care providers' families is to work to be able to understand and listen. And it's so wonderful that so many of the Special Olympics athletes can communicate using words and can communicate really well. But a lot of the individuals that I work with are not in a position to communicate using words, and not in a position to communicate using even body language. So it takes a lot of work and a lot of history and a lot of patience on our part to be able to learn how to listen. So a lot of the time, the lowest hanging fruit, as it were. And this is, again, possibly old hat to many families, but common medical issues, very common medical issues, easily addressed medical issues masquerade as mental illness. And it's a real opportunity for families who are familiar with this to be able to provide education to psychiatrists and healthcare providers who may not necessarily be familiar with this because of the lack of training on the whole, although this is changing, among mental health care providers in the fundamentals of IDD care. What we call this process of misattributing a problem behavior to either a mental illness when it's not, or to someone's disability themselves, which is absolutely dismissing a new problem behavior, saying, oh, and forgive me, I am not saying this, but I'm sure people have heard it. People with developmental disabilities do this, or people with autism just do this. So that's called diagnostic overshadowing. Taking the diagnosis of intellectual or developmental disability and overshadowing overshadowing other diagnoses which are real and need to be addressed, such as pain. What hurts? Those are the most important and fundamental questions. Is someone constipated? When someone is profoundly constipated, I can't imagine I would be on my best behavior. Constipation is a very, very common problem among individuals with developmental changes for a variety of reasons, developmentally, structurally, medication related, potentially diet related, and related to mobility limitations potentially. There's a million reasons that someone can have constipation. GERD, oral health or dental pain, all of these things can be very easily addressed. Medication side effect. I'm going to hold off on talking about the prevalence of how frequently psychiatric medications are prescribed, because this is a talk primarily about intake. How do we access mental health care, and what are the things we think about as we begin mental health care? So that's that I'm going to focus on a different talk. But medication side effects can very frequently cause discomfort that can lead to behaviors. Is someone having seizures? Is someone having GERD or reflux? Social stressors can commonly present with really challenging behaviors, meaning someone's not getting along with their housemate or their roommate. Someone is having difficulty in their relationship. Someone is having difficulty at work. There's a change in staff. There's a change in day programming. Any of those things can create significant challenges, but may not represent mental illness. Of course, we always screen for abuse. And then we learned during the pandemic how profound an impact services can have. So, like I said, it's a puzzle when we're interpreting behavior. A team approach can help solve the puzzle. Of course, the person that we're providing care for has the biggest piece of the puzzle, and it's our job to listen. And I'm grateful to individuals to work with me to communicate, work with me as they communicate their distress. So who is on the team? I work with a behavioral health team, and I work with an overall care team. So the most important person, like I said, is the individual. Family and caregivers have a piece of the puzzle, have a huge piece of the puzzle. You know the individual best, and so it's my job to listen to you. A medical specialist team, I really need input from all of the specialists that we listed earlier. I need to work with a neurologist, a physiatrist, a primary care doctor, a urologist, a hematologist, an orthopod. All of these specialists can provide me with information that helps me interpret behavior and help understand the individual. And then, of course, anytime behavioral dysregulation happens, always we want to involve primary care providers, family medicine docs, internists, pediatricians. These are the people that are going to coordinate care and provide ongoing holistic healthcare. Primary care providers are at the heart of the team. In addition, I tend to lead, but am a part of a behavioral health team. So who's on the behavioral health team? So the behavioral health team is going to be the person integrating the information, such as the psychiatrist or psychiatric nurse practitioner. Psychiatrists in the US and in New York State, MDs and DOs provide some, but the majority, in my experience, of mental health care is being provided by our NP Army, our FNPs and psychiatric nurse practitioners who are leading the charge and leading the way in providing the kind of care that I'm talking about now. Individuals themselves, a psychotherapist. I will always coordinate with an individual's therapist, and thinking that an individual, because they don't have developmental changes, can't participate in psychotherapy is, I'm glad I don't have to justify or reassure this group of athletes and families and clinicians that someone can't participate in psychotherapy because they have developmental changes. A psychotherapist can be an essential member of a team and can provide a real plan and real support in the form of cognitive behavioral therapy, something called DBT, dialectic behavioral therapy, trauma processing therapies that are adapted and can be very helpful for individuals. Behavioral clinicians can help give me the information I need, caregivers, like we said, and then it's really going to be important to pull in care managers. So I work with the four, TRICARE. Life Plan, Care Design New York, any of the four agencies that provide care management. A care manager can really help the left hand know what the right hand is doing and ensure that the right medical evaluations are getting done, ensure that families are aware of all the different appointments, help coordinate care, help connect with services. So care managers are essential. And then, of course, as always, I can't say enough, a primary care provider. So how is mental health care provided for individuals with IDD? How can someone get access to the kinds of comprehensive care that we're talking about? So some families are of means and in a position to be able to find private providers sometimes on a concierge basis. And some people are able to get house calls. Primarily, that's done now through telehealth, but there are private providers who are doing this kind of care. Primarily, you're going to see neuropsychiatrists, behavioral neurologists, people with an additional element of their training, medical training, so geriatric psychiatrists, consultation liaison psychiatrists, doing people who do what I do, neuropsychiatrists, behavioral neurologists provide this kind of care. And then, but those are few and far between and scattered, although the number is growing. There are group practices who have psychiatry departments that and large hospital systems that absorb individuals, absorb populations and don't discriminate necessarily, and have no problem providing care for people with intellectual disability, like the Kaiser system, the Geisinger system, and then there are specialty centers and clinics, like Golisano teaming up with UCP, and our UCEDs, or University Centers of Excellence, the Kennedy Center, the Rose Kennedy Center in the Bronx, places like that. And then all throughout the 50 counties of New York State, OPWDD and the Office of Mental Health provide have clinics that provide care to the general community. So there are some numbers here, like Article 16 clinics, Article 31 clinics, and Article 28 clinics. So those are Medicaid and Medicaid waiver programs that will provide care to the general community. So if you are in crisis, or if you need mental health care, and you are not in a position to have access to a private provider or a large hospital system, the majority of care is going to be provided in your community by an Article 31 clinic. And when it says OMH, Article 31 clinics are overseen by the Office for Mental Health. They are general community mental health care centers, and they're going to be able to provide things like care management. They're going to be able to provide things like psychotherapy, potentially group therapy, and they're going to be able to provide hopefully adapted mental health care and psychiatric care. So I work at an Article 31 clinic that I've adapted. Those are overseen by the Office of Mental Health, and they should be able to accommodate and adapt care to be able to provide services for an individual with IDD. OPWDD, remember I was talking about all these different acronyms. OPWDD has Article 16 clinics. So Article 16 clinics can provide psychiatric health care. They can do sometimes the neuropsychological testing that's needed to enroll someone in OPWDD services. They have sometimes specialty care like physiatry. They can do groups. They sometimes have attached partial programs, but they do not provide primary care. The most comprehensive options are our jewels, our Article 28 clinics. An Article 28 clinic is often, you'll get into acronym soup here, but is often provided along with what's called a federally qualified health center, meaning that which is a designation ensuring they have additional funding to be able to stay open and provide care to all comers. Article 28 clinics are often operated by places like the ARC can have an Article 28, formerly UCP or CP State has them. ADAPT New York has them. Agencies will open Article 28 clinics, and they can provide primary care. They can provide neurology. They can provide audiology. They can provide dental care. They can provide psychiatric care. They can provide prosthetics. They have sometimes OT, PT associated. They are jewels because they can integrate and provide all these services under one roof and really provide integrated, defragmented care. If you have access to an Article 28 and they have openings, that's a wonderful place to start looking. Article 31 clinics, like I said, are where the majority of general community mental health care is provided. Article 16 clinics are often attached to and run by either the state or by agencies, but do not provide primary care. And then you have your other private options. How do I know where to go? So let's say I'm an individual and I'm struggling, or I am caring for an individual or a family member who is struggling. Where do I begin? Because I don't have time to call those places and look, I am really struggling. There's a crisis. We've had some 911 calls. I'm not able to control my behavior. What are the resources available? So New York State wonderfully has no wrong door to mental health care. So in the last 2 years, a national initiative of a suicide prevention hotline has emerged, which is just dialing 988. It's a 911 alternative, and the average length of call is about 20 minutes and does not result in hospitalization, law enforcement dispatch, or in-person dispatch. 988 also will connect anyone in New York State with the either referrals or a person who at the very least will call you back very quickly, and they are connected with OPWDD and with crisis stabilization resources that are sensitive to the needs of individuals with developmental changes. So 988 is a great place to begin. Let's say you're not sure, you don't want to call 911, you don't necessarily want the fire department at your home. You're not necessarily concerned with someone's immediate safety, but you just don't know what to do because a behavior is really problematic. 311 is in many counties in New York State, including the Mid-Hudson area and the downstate areas, is a way to connect with what's called a mobile mental health team, where you can get a call back within several minutes, or they're staffed. Some areas are staffed 24/7. Some areas they'll call you back after 11 p.m. But these mobile mental health teams can go out to the home to help assess the situation. There are social workers and mental health crisis stabilization specialists that can come to your home, work with you, talk about options, and at least work with the family to calm an immediate crisis. And then, of course, the 311 team can provide hospital transport if needed. Those are sort of emergency resources before you end up working with an Article 31, Article 16, Article 28, or one of those private providers, because there's always a wait list there. The other team that's available that's good to pull on board is what used to be called the START program, that advises families, care providers, and advises care coordinators, and has their own medical directors that can review and provide psychiatric second opinions, can really provide wraparound supports in the setting of crises, often in terms of transition. That's a wonderful service. There's a website here, you can Google CSIDD New York START. The limitation there is that someone has to be enrolled in OPWDD services in order to qualify to be able to receive services from CSIDD, which stands for Crisis Stabilization in IDD. They're a wonderful, wonderful resource. So then someone may say, yeah, I've tried all those. I can't find, we don't have a provider that's in my area, that's in a reasonable distance. The wait list is 6 months long. And the mental health infrastructure in my area is not built to be able to provide services. And that is true, but changing. So there is no standardized care. There is no standard for providing mental health care for individuals with IDD. The Americans with Disabilities Act does apply, but in practice is not necessarily implemented the way we would like. in terms of waiting room accommodations, in terms of competence as well. So it's possible to become a board certified psychiatrist in the United States without seeing a patient with developmental disabilities. And we are working really hard to change this. And so, unfortunately, the onus falls upon families, care providers, um, and informal referral networks to ensure that you are going to a provider that is competent and comfortable taking care of individuals with IDD. So how do I know? How do you know that an individual is, or I'm sorry, that a provider is comfortable? Ask questions ahead of time. Call when you make your appointment. What is the waiting room like? I am a person with developmental changes, or I'm bringing someone with developmental changes. How long is the wait? Is the waiting room uncomfortable? Can we go out to the parking lot, and is there a way we can change that? Are there accommodations available? Can we see if an appointment is can be more on time? I'm never on time, but can we see if an appointment can be more on time because it's difficult for the individual I care for to wait? Are there telehealth options? So ask ahead of time, and then I'm sure that the brain trust of the people on this call probably have a robust and wonderful referral network of psychiatrists that you may have, that you don't want to say are out there because you don't want them to get flooded, but share the word. And parent, family, social media networks, utilize word of mouth. Agency recommendations. Call your local ARC. If your local ARC doesn't have a clinic of their own, they may be able to help your care navigator or care coordinator get you into a clinic. They can provide families with potentially referrals in your county or at least adjacent counties. So use your network. You have more resources than you may realize. So I wanted to just offer a couple thoughts on what to do ahead of time. How do we prevent crises ahead of time? First of all, everybody who can, if you can, as early as possible. It takes so much work, and it takes active families. It's really hard after the age of 21. If you have not already been enrolled in OPWDD services as a child, it is really, really tough, but can be done. And we work to get that done all the time. It can be done. Get enrolled in OPWDD services. It doesn't mean you need to take advantage of them, but you don't want to need those resources in crisis because it can take so long. It can take several reviews. So there's a link here, opwdd.ny.gov/get started. They have a front door office whose job it is to help guide families and individuals through the process of getting enrolled. Once you're enrolled in OPWDD services, resources become available, such as those crisis stabilization resources. Clarify issues of guardianship early. It's very challenging when individuals and advocates, parents, caregivers who don't have guardianship disagree on plans. And when there are disputes in the setting of behavioral health crises, they can add a layer of complexity that can really prolong challenges for families and individuals. So clarify guardianship early. And that's also true of medical crises. Of course, there is every reason to do that. But you're also preparing yourself to make sure that if any challenges come ahead, that you've clarified some of those issues. And I won't get into stories there, but overall healthcare is preventative mental health care. So making sure you're up to date with your GYN screenings, your dental visits, your primary care visits, audiology and vision care. It's really hard to maintain good mental health if you can't hear what's going on around you, and if you need glasses, and if you're tripping over things and you can't recognize the world around you, it's really tough. So sometimes we've been able to do wonders just by getting someone the right hearing aid, of course. Special Olympics is mental health care, not just through the Strong Minds program, but through socialization, through programs, staying active, staying connected. I did a study along with a colleague of mine at the University of Colorado, the wonderful Dr. Jesse Sanders, where we did surveys of individuals through the pandemic of self-reported mental health care outcomes, because we had never before seen a time when everything shut down and when services and Special Olympics, day programs, ComHab services were completely interrupted, and we wanted to be able to track how individuals reported their mental health. And of course, unsurprisingly, as we all experienced, we saw tremendous impacts in terms of anxiety, depression, self-injurious behaviors. There were a small number of people that actually did better, and we saw that, oh, okay, well, maybe our idea of getting everybody out and about isn't necessarily perfect for everyone. There are some people who like to nest, but overall, this is a Special Olympics. Hosted forum, and I can say that that physical activity was linked to improved mental health outcomes, day programming, staying connected. So maintaining day programming and activities and social connection is so key. I'm not going to talk about other mental health and wellness resources because that's so individualized. In the general population, we may recommend certain apps, we may recommend books. I'm not going to say that because I really feel like, if you've met a person with IDD and autism, you've met a person with IDD and autism. It's not the recommendations I would make to them do not apply to everyone. And I just want to rely on teams to be able to tailor individualized supports or any kinds of app-based or therapy-based supports. For them. Preparing for transitions early. You can't begin early enough to transition from to prepare for potentially greater independence, to prepare for transitions to congregate settings, to prepare for transitions to work, and to prepare healthcare transitions. So that can be really helpful in crisis prevention. So a lot of people want to know what it looks like and what it means when you're going to get your mental health care. You need mental health care. What does that mean for me? Okay, I've made my phone call. Where do I start? Am I going to see a therapist first? What's going to happen? How am I going to pay for it? What are they going to need from me? What does it look like? Every agency, every clinic, every place has their own process. I would just say, again, start with phone calls. They'll walk you through the steps. Don't be afraid to make that first call, and then update your primary care physician. I can't tell you what your mental health journey potentially is going to look like, depending on where you're getting those services. Article 16, Article 28, Article 31, private care system, large university system. I can't tell you what the journey is going to look like, but I can tell you what you're going to want to bring to the table as a family member, as a care provider, as an individual. So what you're going to want to bring to the table is the information that a team needs so that the right hand knows what the left hand is doing. Communication is going to be key. I can't say it enough times. Communication is key. So the biggest pitfalls can always be avoided by working collaboratively. The biggest and most important thing right off the bat is make sure you have an accurate medication list that everybody has. Because medications have interactions are not necessarily benign. That's the lowest hanging fruit. An accurate medication list, an accurate allergy list, and then information available. So because multiple observers can help us get a full picture, provide your mental health care provider with the information they need so that they know who is on your healthcare team. I want to know if I'm your psychiatrist or if I'm taking care of you. I want to know who your primary care doctor is, who your guardian is, who the important people are in your life. What specialists do you see? I'm going to want to know who, if you're living in a congregate setting, who the staff members that know you best are. I'm going to want to know who your house nurse is. A sheet telling me who the people that matter in your life are is going to be so key to me. Multiple observers are needed to get a full picture. So the kind of input we need, like I say, I keep repeating these things over and over. It's so key. I need input from the individual I'm working with. I'm going to need input from the nursing staff. So tell me who they are, family members. Okay, this is going to be a little redundant here, so I apologize. But I'm going to also need objective data. I'm going to need baseline health and behavior information, a good medical history. Do you have epilepsy? Tell me what kinds of other health challenges you have. How often do you go to the bathroom at baseline? What is your bowel habits like? What is your eating like? What is your sleep like? All of that at baseline before you had the challenges. What have you been like your whole life? Because I'm not going to want to treat something if I'm going to want to know if something has always been there and if it's actually a problem. And it also, that kind of information can help guide our medication decisions when we're going to use them. So I'm just going to finish by saying that that it's very frequent that individuals will go for psychiatric care and be treated on a symptom-based basis. If they are being treated for symptoms and don't have a diagnosis, that's not necessarily best practice. For all the clinicians on the call, make sure that when you're prescribing a medication, you have a diagnosis associated. And if you don't have a diagnosis, that you have a very clear symptom-based, a very clear reason for symptom-based approaches to treatment. There are some resources that can help you make a clear diagnosis, which from the NADD, the National Association for the Dually Diagnosed, meaning someone with a mental health diagnosis in addition to a developmental change. They're a wonderful group. They published the DMID2, which is an adapted DSM-4. The psychiatry, I'm sorry, DSM-5, the Psychiatry of Intellectual Disability is a wonderful textbook by Dr. Gentile. That gives case examples and is a practical guide for clinicians who are starting out taking care of individuals with IDD, and also online resources for clinicians. There's a UCED, which is a University Center of Excellence in Developmental Disabilities out of Vanderbilt. Vanderbilt University, the Vanderbilt Kennedy Center has an IDD healthcare toolkit that can be very helpful for individuals, for caregivers. And within that is a behavioral healthcare toolkit that has terrific checklists that you can use along with families, individuals to track symptoms, to help interpret behaviors based on an ABA model, and can help track and monitor for side effects. Some wonderful concrete tools in addition to risk management. And here are some relevant organizations. The AADMD, I will sing the praises of to no ends. I sit on their board. That's the American Academy of Developmental Medicine and Dentistry. We've actually succeeded in getting, I talked before about making changes. We've succeeded in getting a core component. You cannot graduate as a dental resident now as a result of the work of the projects through the AADMD called the National Curriculum Initiative in Developmental Medicine. You cannot graduate as a dentist from residency without some exposure to disability care. And of course, we'd want more, but you have to demonstrate that you've had training in disabilities care, and we're going to get there in medicine as well. The NADD I mentioned, as well as the NADD.org. They're based here in Kingston, New York, and are a wonderful organization that gives talks and does nursing certifications. And has some wonderful educational resources for what I do. There's the ANPA, the American Neuropsychiatric Association, AAN, and APA all have journals, work groups in IDD and autism, and are terrific resources for a brain trust for colleagues that work in the same space. So I think, oh great, I made it right at 50 minutes. We had talked about 10 minutes for questions. Please let me know.
Sure. So
Here's my email as well. That's my work email in case anyone needs any questions. Sorry to speak over you, Taylor. I apologize.
no problem. So thank you so much, Dr. Margolis. A lot of great information here. So just want to put it out to anyone that we have 10 minutes left. If you would like to pop a question into the chat, we can absolutely go through those to get through a couple of questions. I also will include a link in the chat for the form that you can fill out to submit a question or any feedback that you would like to after the presentation tonight. Just to let everyone know, we will have this presentation recorded and send that out to those that were unable to hop on right at 6:30. So if you did register to attend, I have your contact information and can send that out to you, no problem. And we will also get it up onto our Special Olympics New York pages so that it is accessible to everyone. So if you'd like to share with colleagues that maybe weren't registered tonight but would find this information super helpful, please feel free to pass that along. And then also in that form that I popped in the chat, there is the opportunity to give us some feedback regarding some upcoming topics that you'd be interested in hearing about regarding health and the IDD population. We're always looking to make sure we're providing useful resources for everyone. So if you have any topic suggestions, please send those over. So I will look at the chat here. So it does look like we have a question. Can individuals with behavioral challenges like aggression realistically safely participate in Special Olympics?
I would say that that individuals with behavioral challenges like aggression have, in my experience, often far fewer challenges with aggression when they are participating in Special Olympics, and that Special Olympics can be a wonderful and enriching thing in preventing behavioral challenges like that, and can connect someone. Special Olympics is a wonderful place where someone who starts having emerging difficulties can get connected to the kinds of resources to help manage to help that process started. So if you're having difficulty to the point where it's preventing you from participating in events and athletics now, let's stay connected. And aggression and these problems do not last in most individuals forever. They are symptoms of a problem. We help interpret it, we help address it, and help someone live their best lives. And I don't see any reason why Special Olympics can't be part of it. But sometimes you do have to pause while we address those challenges. But absolutely.
Dr. Margolis and Stacy Hangsterman, and I am joining tonight in my sweatshirt and pajama bottoms as a mom and also president and CEO of Special Olympics. I was so excited for this talk. I loved your answer, and I would agree that we would love to give it a try, and it would help with aggression. We have an athlete code of conduct, and that does provide a framework for the athlete. And if it's something that they really want to do, you adhere to the athlete code of conduct, but we work through it with them. So whoever asked that question, I think I would love to be able to work with it and see what we can do. And I just want to say thank you as a parent. I already screenshotted a few of your things, and I appreciate all that you do for Special Olympics and our athletes.
Oh, thank you.
And us parents.
Honored to be on the team. Absolutely honored to be on the team. Thank you. So great.
Any other questions in the chat here? And remember, we can have folks submit later on if you think you might have a question but not quite sure how to ask it now. You can utilize that form.
I have a question about guardianship. I know I have to do it. It's like half done on my list of things to do. Have you seen case? I mean, I am realizing my son is 19, and I'm kind of, when I'm calling and say I'm calling for my son, when are they going to push back? Have you seen real problems with not having guardianship? That I saw that it was like your number 2 thing.
Yeah. So the problem with guardianship and when it's really emerged is unfortunately in the setting of paternalism. The setting in which I've experienced the greatest degree of difficulty is when someone is their own guardian and their parents are either something happens to their caregivers, which is just such a challenge for everyone. But then when there's the added layer of successor guardianship not appointed, or when parents are no longer able to care for their loved one, uh, their family member, or a caregiver is no longer able to age or another reason able to provide care, and there is a disagreement about the kinds of supports that someone needs. Um, uh, in addition, in the setting of neurodegenerative difficulties like Parkinson's or Alzheimer's, when someone has an increased level of need, and yet they are able to refuse. They are able to refuse. It really can delay someone getting the supports they need. They'll be in an apartment for longer than is safe. They'll be in the community in settings that are not safe, and we see things like financial exploitation in that setting, where where the individuals can be taken advantage of. See things like just falls and fractures. I can talk more. I'm being as general as I can, but I can give some sort of some
no, that's good. Yeah.
stories
No, thank you.
time.
That's good.
Yeah.
I know there's other questions in the chat too.
Oh, sure. Sorry. Yeah. Oh, great. So therapies for OCD. Absolutely. So OCD is a great example of a condition that is best supported and managed with a combination of medication and therapies. OCD can be managed really well with exposure therapy, with a behavioral support plan. So if someone gets stuck on things, and they can ramp up to getting to having real safety challenges, a plan can be made with caregivers and with the individual, with staffing, to be able to support them through it. Absolutely, a team approach to managing OCD and autism-related OCD can be really helpful. CBT is absolutely appropriate for teens and adults with IDD, depending on how significant they are affected by their intellectual disability. There are different degrees of adaptations that are available. There are texts that can help support those, and I'd have to get those to you offline. But absolutely, CBT can be used really successfully. So grief responses. I'm so sorry. Let's see. So someone asked a question about grief supports. So grief is so real and so much, and we're all coming off of a flood of it as we lost so much over the past 4 years. So specific grief supports may be available through depending on the again how your socialization is affected, how you interact with the world. If you are an individual who's grieving and who navigates pretty independently, without some particular needs, you may be able to participate in grief groups. So most local hospice organizations offer either online or in-person grief supports. So there are specifically sometimes young people's groups, and sometimes groups and supports for all ages. In addition to being able to provide referrals for specific grief counselors, grieving is a normal part of life and can be normalized, and this may sound nuts, but grieving can be a life skill, and understanding how to process, giving ourselves permission to process, giving ourselves time to process can be really helpful. Grief can we used to give someone 6 months before we would say, well, we would expect a return to more more normal living after 6 months after losing someone close. And now we give it at least up to a year before we start giving it a DSM diagnosis. We just call it a bereavement reaction now. But certainly there are resources, and look for your local hospice.
Great. Wonderful questions, everyone. Thank you so much for not only hopping on tonight to listen to the presentation, but for also really actively being involved with Dr. Margolis's presentation. So with that, Dr. Margolis, we are so lucky to have you as part of the Special Olympics New York Health Advisory Council and as a huge supporter of our work and for the health of people with IDD. Thank you so much for taking the time to present this evening, and I'm sure that we'll have some other folks with some questions and some feedback, but what a wonderful presentation. Thank you so much for your time.
Thank you. All right. Great to have been here. Thanks again.